Heart failure medications. Part 3, add-on agents. In Part 3, we'll talk about adding on additional medications to traditional drug therapies. Let's first talk about Ivabradine. Prior studies have shown that an elevated resting heart rate is a risk factor for heart failure for adverse outcomes. This provides evidence for the benefit of lowering the heart rate in patients with heart failure. Ivabradine is a selective IF or funny current inhibitor which lowers heart rate by acting on the sinoatrial node or the pacemaker. It does not affect blood pressure, myocardial contractility, or intracardiac conduction. Here's where Ivabradine works. It blocks the sympathetic nervous system along with the beta blockers to decrease heart rate. The benefits of Ivabradine were demonstrated in the SHIFT trial, which was published in The Lancet in 2010. 6,505 symptomatic heart failure patients, mostly New York Heart Association Class 2 and Class 3, were studied. Their ejection fractions were less than or equal to 35%. Their resting heart rates had to be at least 70 beats per minute. They needed to be taking beta blockers at their highest tolerable dose and hospitalized for heart failure within the past year. Approximately 92% of patients were receiving ACE inhibitors or ARBs in both groups. Ivabradine was titrated to 7.5 milligrams twice a day to maintain a resting heart rate between 50 and 60 beats per minute. The trial lasted for 23 months. The results of the SHIFT trial showed that compared to placebo, Ivabradine significantly decreased death from cardiovascular causes or hospitalization for heart failure, with a p-value less than 0.0001. This was driven primarily by a reduction in the need for rehospitalization for heart failure. This was a significant finding with a p-value of 0.001. More on the SHIFT studies showed that most of the benefit was observed in patients with heart rates greater than 77. Only 26% of patients were taking target doses of beta blockers. 10% of all patients were not taking a beta blocker. And patients treated with Ivabradine had an average reduction in heart rate of 8 beats per minute. As stated earlier, Ivabradine is a selective sinus node inhibitor via the IF funny current. It has no other hemodynamic effects. It affects heart rate only, and it has no inotropic effect. The indication is to reduce the risk of hospitalization for worsening heart failure in adult patients with stable symptomatic chronic heart failure with reduced left ventricular ejection fraction. Ivabradine is known as Corlenor, and it's manufactured by Amgen. The initial dose is 2.5 to 5 milligrams twice a day orally. It needs to be taken with food. The usual target dose is 7.5 milligrams PO twice a day, titrated to a heart rate of 50 to 60 beats per minute. The price per month is about $500 wholesale acquisition cost. Ivabradine caused symptomatic bradycardia in 5% of patients compared to 1% in placebo, which was statistically significant. Ivabradine decreased heart rate by 15 beats per minute over placebo. Ivabradine also can cause a temporary vision disturbance or flashes of light caused by phosphagenes in 3% of patients versus 1% of placebo. And Ivabradine needs to be avoided in pregnancy. So the recommendation for Ivabradine is that it's indicated as an add-on drug for patients with heart failure in sinus rhythm with a heart rate of 70 beats per minute or greater, despite maximally tolerated beta blockers. According to published guidelines, Ivabradine may be considered in appropriate patients, but the beta blocker should first be titrated to the target dosage if tolerated. Let's move on and talk a little bit about vasopressin antagonists. We know that vasopressin or ADH concentrations are elevated in acute heart failure. ADH can activate the vasopressin receptors, and there's two types. The first type is called V1A receptors, which when activated in the systemic vasculature causes vasoconstriction. The second type are V2 receptors, which are more important in heart failure, where activation in the kidneys leads to a decrease in free water clearance. This can lead to fluid retention and hyponatremia, thereby worsening heart failure. So can we use vasopressin receptor antagonists in heart failure to block the increase in ADH? Vasopressin receptor antagonists include a drug called conivaptan, which is a dual vasopressin 1A and vasopressin 2 receptor antagonist. Unfortunately, conivaptan is only available as an injectable. Tolvaptan, on the other hand, is a selective V2 receptor antagonist. It's an oral tablet, and it increases urine output without causing sodium loss. So would vasopressin receptor antagonists be beneficial in heart failure? This was studied in the Everest trial. The Everest trial studied the efficacy of vasopressin antagonism using tolvaptan in heart failure. 4,133 patients with acute decompensated heart failure with a New York Heart Association Class 3 or 4 rating and left ventricular ejection fraction of less than 40% were studied. All patients also received standard therapy: ACE inhibitors, ARBs, beta blockers, diuretics, nitrates, and hydralazine. The patients were randomly assigned within 48 hours of hospitalization to 30 milligrams per day of tolvaptan or placebo. The results of the trial showed that tolvaptan modestly improved patient global clinical score, body weight, and congestive symptoms and overall hemodynamic profile at day 7. The main clinical benefit was driven primarily by weight loss. Unfortunately, there was no significant benefit in other clinical outcomes. No improvement in long-term outcome. The trial failed to show any significant differences between tolvaptan and placebo in all-cause mortality, cardiovascular mortality, or hospitalizations for heart failure. The combination of hydralazine and isosorbide dinitrate results in vasodilation, thus improving prognosis in patients with heart failure with reduced ejection fraction. Hydralazine provides symptomatic relief of heart failure by decreasing afterload. Nitrates have venous dilating properties that decrease preload. Used in combination, these two agents have additive benefits in alleviating the symptoms of heart failure and increasing exercise tolerance. The benefits of this combination of drugs was demonstrated in the AHEF trial, or the African American Heart Failure Trial. 1,050 Black patients with heart failure and New York Heart Association Class 3 to 4 symptoms were studied. Hydralazine and isosorbide dinitrate were added to optimal doses of ACE inhibitors and beta blockers. Initial dose was hydralazine 25 milligrams twice a day plus isosorbide dinitrate 20 milligrams 3 times a day, with a target dose of hydralazine 75 milligrams 3 times a day plus isosorbide 40 milligrams 3 times a day. The results showed compared to placebo, hydralazine and isosorbide decreased all-cause mortality as well as decreased hospitalization for heart failure. The AHEF trial showed that the addition of hydralazine combined with isosorbide dinitrate to standard heart failure therapy with an ACE inhibitor and a beta blocker improved survival and reduced heart failure hospitalizations. Hydralazine isosorbide dinitrate added therapy should be considered for use in Black patients with persistent symptomatic heart failure with reduced ejection fraction with an LVEF at or below 35%, despite conventional therapies of ACE inhibitors, beta blockers, and diuretics. Hydralazine isosorbide dinitrate is also an option for those intolerant of ACE inhibitors and ARBs because of renal disease. Please remember to avoid using isosorbide concurrently with phosphodiesterase inhibitors such as sildenafil, Viagra, due to additive hypotensive effects with nitrates. Some adverse reactions to monitor for are hypotension, headache, dizziness. Hydralazine alone can cause lupus-like syndrome and tachycardia. Isosorbide dinitrate hydralazine is taken 3 times a day, making compliance a challenge. Diuretics. Diuretic therapy, loop and thiazide, is essential when needed to manage volume status in patients with heart failure. However, diuretics do not provide mortality benefit or improve survival in heart failure patients, so they should be used only when needed to relieve symptoms, treat pulmonary congestion, and or to control fluid retention. They produce rapid symptomatic relief. Once the excess volume is removed, therapy is aimed at maintaining sodium balance and preventing accumulation of new fluid while avoiding dehydration. Loop diuretics, such as furosemide, bumetanide, and torsemide, are the preferred initial diuretic agents. In the setting of loop diuretic resistance, thiazide-like agents, most commonly metolazone, might be added for a synergistic effect. Monitor electrolytes, especially for hypokalemia. Here's a nice table that reviews the dose equivalency and duration of action of various loop diuretics. Digoxin. Digoxin works as a positive inotrope and can also be arrhythmogenic. Digoxin should be considered for those who remain symptomatic despite therapy with all other heart failure agents. In the only large controlled trial of digoxin in patients with heart failure, digoxin had no impact on mortality but decreased hospitalization rates. Unless the risk of toxicity outweighs the benefit, discontinuation of digoxin is generally discouraged because an association between withdrawal therapy and worsening heart failure has been well documented. It is important not to withdraw digoxin in heart failure patients who were stable and tolerating digoxin, especially those experiencing frequent hospitalization. To summarize, we previously stated which type of heart failure patient will benefit most from the addition of Ivabradine based on the SHIFT trial. We explained why vasopressin receptor antagonists are not recommended for heart failure patients. We identified which group of patients would benefit most from the addition of hydralazine isosorbide, and we defined the current role of the use of digoxin and diuretics in heart failure. Coming up next in part 4 of this series, we're going to describe the mechanism of action of SGLT2 inhibitors, outline the heart failure indications for SGLT2 inhibitors, explain the mechanism of action of vericiguat, define vericiguat's FDA indication for heart failure, and discuss vericiguat's dose, kinetics, drug interactions, and adverse reactions. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.